Good morning, everyone. Good morning. It's 9:30, and so we want to go ahead and get started. I know many of you have been here for some time now, and hopefully you had breakfast and your caffeine in you, and you're ready to get started with us. So happy Monday, and welcome to NHSN 2017 Training Long-Term Care Session. We have a packed agenda today, but before I get started, I've been asked to share a few things with you. For this conference area, they have some safety briefing that we have to share with you. In the event that there is an emergency and we all need to evacuate, we just ask everyone, follow the exit signs and assemble on Michael Street. That's actually behind this building, but I'm sure if we're all going out together, we'll go in the same direction. And at that point, we'll receive directions as to whether or not we would come back in or we have to leave the campus or whatnot. And I just have a few housekeeping things. There are continuing education credits available to everyone. There's information about that and how to obtain that in your folder. For those who are watching online, there should be an email that will be sent to you with further instructions. We're taking attendance, and Avaris is actually the conference contractors who's helping us set everything up today. You've been interacting with them probably this morning already. We just want to make sure that you're reminded to check in with them every day. There's also an opportunity for you to interact with your speakers. So you'll notice on your table there's a little orange bucket. It has polling devices available to you. Hopefully there's one for everyone at your table, but if not, be a kind neighbor and share with the person with you. But make sure that you return it at the end of the session. We don't want any missing devices. And also, as you notice, we welcome food and snacks in here. We want everyone to be comfortable. We have some treats for you at the table. I noticed that many of you have found a cafeteria already, so that's good. You probably saw the vending machine there. I believe there's another vending machine down the hall and to my right if you need to get something else. And I know for lunch options, some of you have already opted in to buy a box lunch, but if you did not do that, the cafeteria is also available to you. We ask that no one take any pictures, and please silence your phones for the courtesy of your neighbor and for the presenters. And finally, we ask everyone hold their questions to the end of the presentations. We'll have a time for people to go to the mic and ask their questions. And many of you may have some burning questions about particular cases or experiences that you've had in your workplace, and we just ask that if you have anything specific to a particular patient or a particular case and it's very detailed, that you reserve that question and send it to nhsn@cdc.gov. We also have to disclose the fact that we have no financial conflicts, no commercial support had been given for the continuing education activities. And all the examples that you will see today are fictitious. We don't use actual data from NHSN in any of the presentations today. And so, now that I got that all out the way, welcome again. We're so excited to have you all here. I have to say, the long-term care team, we've been anticipating this moment for quite some time, and we look forward to the opportunity to interact with you all. I have the pleasure of being your first speaker today. My name is Jeneita Bell. I'm the long-term care team lead for NHSN. And today I will talk to you about infection surveillance and prevention in long-term care from a national perspective. Usually when I do talks on surveillance, I like to start with the definition of public health surveillance. I've found in just my everyday life, when people hear surveillance, they typically think of the NSA or Big Brother watching you from many monitors in a room. My family thinks so anyway. But CDC has defined public health surveillance as the ongoing systematic collection, analysis, interpretation, and dissemination of data regarding a health-related event, so it can be a disease or condition or injury, to reduce morbidity and mortality and to improve health. Public health surveillance has many characteristics, and primarily it's used to provide data to facilitate prevention and control of a health condition. Its objectives determine how the data is collected and analyzed. It has many attributes, and I listed some of them here. The first one I have here is acceptability. That reflects the willingness of people or organizations to participate. There's also sensitivity, which refers to the proportion of cases of a disease that the surveillance system captures. Positive predictive value is the proportion of cases that actually represent or have the health-related event of interest. Timeliness often refers to the time interval between when a case actually occurs and when it's reported into a surveillance system. Stability refers to the reliability of the system and the availability of it when you need it. And representativeness is the degree to which it accurately describes the occurrence of a health-related event over time and its distribution in the population by person and place. And so, instead of trying to continue to describe this to you in an abstract way, I have a few real-life examples I think you may be able to relate to. The first one is my absolute favorite. I think it's been my favorite since I've been here at CDC. When I first saw it, it was really compelling to me. This is a map of the U.S., and it depicts the prevalence of self-reported obesity among U.S. adults by state and territory. The BRFSS is the Behavioral Risk Factor Surveillance System. Some of you may have experience with it, but it's one of the largest systems that CDC has. It's implemented on an ongoing basis, and the data is required by conducting random interviews. So some of you may have been contacted. They conduct phone calls to landlines and cell phones and collect information from people. And apparently they collect enough information to be able to calculate a body mass index and determine whether or not you're obese. And so the data here represents that. But before I move on, I want to make sure I orient you to the map a little bit more. If you look at the lower right-hand corner, you notice that the green color represents the lower prevalences, with the highest being orange and red. Red is greater than or equal to 35%. So I have a few slides with this same map. I want you to pay attention to the color and where it is on the US. So first we have 2011, and 2012, 2013, 2014, and 2015. So I think this map is a beautiful depiction of how surveillance can benefit you. It highlights the benefits and the trend data that's available. And in a matter of seconds, I was able to convey to you the burden of obesity in the United States, how that has changed over time, and what regions are the most adversely affected and the least adversely affected. So that's surveillance, one thing surveillance can do for you. You can also conduct surveillance over a smaller time frame. The example that I have here is what we often call in public health an epi curve. We do this when outbreaks occur, but it's basically essentially a bar graph. And this bar graph shows diarrheal illness in city residents by date of onset and character of stool from December 1989 to January 1990. On the horizontal axis, you have time, and on the vertical axis, you have the number of cases. And the different shades of the bar graph represents the character of the stool. You'll also notice that there's some historical data mapped onto the bar graph. And let's look a bit closer at the graph so you can see what this is depicting. Around December 16th, they noticed their first case of diarrhea. The cases began to increase over time. And you notice when the water main breaks, the increase continued and peaked around January 1st. Then a boil water order was issued. They saw a small decline in cases, but it wasn't until chlorination occurred of the water that cases have been gradually declined and then no longer were detected. So not only were the investigators able to characterize the trend of this illness over a small period of time, but they're also able to look at historic data to determine what a potential cause or prevention may have been for this particular outbreak. Do we need this for long-term care? I have no doubt in my mind that all of you would agree with me and answer that question by saying yes. Some level of surveillance probably already occurs in long-term care facilities, particularly similar to the example that I just gave. In the event that there's an outbreak, you want to track cases and understand what the cause and prevention was. But let's talk about this on a national scale. I want to proceed with my presentation by telling you why I believe this is needed in long-term care and how NHSN can help meet that need. So we know from epidemiological studies of long-term care facilities that there are over 4 million people who are admitted to or reside in nursing homes and skilled nursing facilities each year. Infections are the most frequent cause of transfers and hospital readmissions, and an estimated 380,000 deaths occur every year as a result of infections. Approximately 2.8 million infections occur in nursing homes and skilled nursing facilities every year, with the most frequent being urinary tract infections, lower respiratory tract infections, skin and soft tissue infections, and gastroenteritis. In support of this evidence, you'll see this table here. In 2011, the Office of the Inspector General conducted a study among skilled nursing facilities and looked at adverse events. 653 facilities were observed, and a report was released in 2014. The adverse events were categorized into 3 categories: events related to medication, resident care, and infections. Infections represented 26%, and that's what's represented in the table here, with the most frequent being aspiration pneumonia and other infections, SSIs, catheter-associated UTI, and Clostridium difficile infection. So although, you notice in this table, although CDI represents a small proportion of the infections, it's still a significant event because of the associated morbidity and mortality with Clostridium difficile. Not only that, it's a public health threat. CDC even included it in its antibiotic resistance threat report of 2013. At least 250,000 CDIs occur per year. 50% of CDI occur in people younger than 65. However, more than 90% of deaths occur in people 65 and older, with 50% first showing signs and symptoms while they're in a nursing home or shortly after visiting a doctor's office or clinic. Colleagues here at CDC conducted a more in-depth analysis of nursing home onset CDI in order to determine what the burden is in the United States. They conducted a surveillance sampling of 10 geographic areas and derived a 2012 national estimate. They found that in 2012, approximately 112,000 CDI cases were nursing home onset. And upon a medical review of a sample of those cases, those who were infected had a median age of 82 years, and 76% had received antibiotics. Now, so the data that I've presented to you so far may seem sufficient, but there are some limitations that we need to overcome and to better inform prevention efforts. For example, the data that I presented to you, some of it, was derived from hospital surveillance, and that may not accurately capture nursing home admissions. National estimates that I presented in the previous slide were extrapolated from few geographic areas, and therefore the representativeness can be questioned. Incidence estimates from that study as well are not based on nursing home populations because of the lack of denominator data of the overall nursing home resident population. And so all of these things collectively cause us to underestimate the true burden of healthcare-associated infections, or HAIs, in nursing homes across the U.S. And also, they lack the details necessary to conduct national, state, or facility-level prevention on some levels. So how can surveillance help? Well, the definition I gave to you earlier, that surveillance is the ongoing systematic collection, analysis, and interpretation of data. And that alone allows you to characterize the national burden of HAI, establish a national baseline for the incidence of HAI, identify associated risk and protective factors, evaluate intervention effectiveness, and monitor incidence trends and identify outbreaks. NHSN was created for this purpose in recognition of these many data gaps. Although NHSN was launched in 2005, the long-term care component did not become available until September of 2012. It has modules for the reporting of UTIs, multi-drug resistant organisms, and adherence to hand hygiene and gown and glove use, and CDI. All of these will be discussed in detail by the presenters that follow me. They will describe to you how standardized definitions help with the systematic collection of data and how those data can then be analyzed to help you understand epidemiology of any health event within the facility and between facilities. So here I have a few maps just to show you how participation in NHSN has grown. Approximately a year after its launch, we had 130 nursing homes participating. June of 2016, we had 307. And as of March this year, we have more than 2,000 nursing homes in NHSN, representing more, 50 states, all 50 states, DC, and Puerto Rico. And this is important. The growth and participation will set up the framework and allow us to take public health action and will inform prevention efforts. So, but to this point, I focus mainly on, the national perspective and the benefits that it can have for us to help fill data gaps. But I want to make sure that I acknowledge the benefits that it can have, particularly for long-term care facilities at a facility level. So there's other needs, and I recognize, especially in nursing homes, that you all have many masters to serve. And it's important that if you adopt something like NHSN, that it helps you kill more than one bird with one stone. So I have a few examples listed that I could think of. There's a Quality Assurance and Performance Improvement Requirement, or QAPI, Infection Prevention and Control Program, Antibiotic Stewardship Program requirements, and local interventions you may want to do within your facility itself. So let's start with Quality Assurance and Performance Improvement, QAPI. As many of you already know, there's a section of the Affordable Care Act that requires CMS to establish regulations and quality assurance and performance improvement and provide technical assistance to nursing homes to help them develop best practices to comply with the regulations. CMS has identified 5 strategic areas that I have listed here that are considered the basic building blocks of an effective QAPI. I mapped them here and I placed NHSN at the center because I believe it's related to all these elements. When you decide to participate in NHSN, it has to be part of a greater plan, and you have to have buy-in from your leadership. But for an example, element 3 is probably the most obvious link. It states that there should be feedback, data systems, and monitoring it states that the use of performance indicators should be implemented to monitor care processes and outcomes, review findings and against performance benchmarks, track, investigate, monitor adverse events, and prevention implementation. All these can be done within NHSN. Infection Prevention and Control Program, or IPCP. You all also know that CMS reform requirements for long-term care stated that facilities should develop an IPCP program and include at minimum a system for preventing, identifying, reporting, investigating, and controlling infections and communicable diseases. It requires facilities to have written standards, policies, procedures for a system of surveillance designed to identify possible communicable diseases or infections, and there should be reporting requirements in place for possible incidents of communicable diseases or infections. So in this case, long-term care facilities don't have to start from scratch and reinvent the wheel. All of these things are available to them through NHSN in order to fulfill these specifications. For antibiotic stewardship programs, there's also reform requirements listed in the rule that was released by CMS last year. And it states that in addition to the IPCP program, there should be an antibiotic stewardship program, and facilities should designate at least one infection preventionist. The program should include antibiotic use protocols and a system to monitor antibiotic use. Now, NHSN does not have an antibiotic stewardship or antibiotic use module yet. We're working on that. But there's other features that a facility could use. For example, CDC's core elements of antibiotic stewardship is actually represented on the annual surveys that facilities participating in NHSN has to complete every year. The UTI module allows for one to report antibiotic use, And then there's the Lab ID module that will allow you to report on organisms that are related to antibiotic stewardship. So all these elements can be used to help facilities determine what their framework is, its effectiveness, and performance regarding antibiotic stewardship. So up until this point, I've been idealistic in my presentation, and I want to take a moment and acknowledge that there are some challenges with NHSN. Everything has its pros and cons, and NHSN is no exception. So I have to say that the long-term care team has taken a systematic approach. We know that there are some barriers and challenges that are inherent to the system itself, but we're grateful for the opportunity to receive feedback from you all, because you all are using the system in a way that we can never use the system. And so we want to make sure that the function of NHSN is conducive to your working environment and how you have to deal with things on a regular basis. We take note of all those things that come into us. We've listed some things ourselves, which is represented in the table, some of them. And we try as immediately as we can to develop short-term solutions to resolve issues that users bring to our attention or we come across ourselves. But I have to say that the feedback is also important because it equips us with the information that we need to petition our leadership for long-term change. So some things need to happen from an infrastructure standpoint and won't happen as immediately, but we can at least get the ball rolling so that you'll have a better NHSN experience in the future. And we can continue to advocate on your behalf. Now, I hear laughter in the room. Some of you all have the unfortunate experience of NHSN 8.6 defects. With the release of NHSN 8.6 in January this year, we had widespread technical difficulties. It affected all components, all stages of user participation from enrollment to analysis, and it even affected our internal data systems. I have to say that I thought this picture was fitting because there were days where the team came to work and we were all like this at our desk, because it's frustrating to know that we are inhibited in our own work, but to know that you are inhibited in your work. We want to make sure that this thing runs smoothly on your behalf. I have to say that the IT teams are constantly on task, and they resolve many of the issues that came along with 8.6, and some of them are still, to come. And then it was just an unprecedented experience. And some of you who are already users of NHSN, you know also that the application was taken offline last week because some security vulnerabilities were detected. And I have to say, though, that no data breach occurred. I want to assure you of that. And they're working on that. We're expecting an announcement today, an update as to where we stand with that. But it was unscheduled maintenance, but it's done for the protection of the information that's in there. We have to secure the data and protect people's information, their health data. But with all that being said, I still think there is hope. Whatever defects that have occurred and probably will occur in the future and other technical difficulties, the long-term care team and the folks over at NHSN are really dedicated to making sure that we accomplish our mission at hand. I mean, we're all in public health because we have a heart for people. We have a heart of service. And so we were all disturbed by the things that you experienced that inconvenience you and challenge you in your workplaces. But we have to keep the ball moving and moving forward with our mission to protect public health and long-term care communities. And we're very dedicated to that. And so the defects will be repaired. The technical issues will be resolved. And we appreciate your patience and the patience you've given us thus far to help resolve those things. Now that I've acknowledged the elephant in the room, I hope that, I just hope that, moving forward with today's sessions, that we'll be able to at least focus on the content here, because this is an opportunity we don't get often to interact with you all, and you have the subject matter experts at your disposal. I just want to make sure that we use that to our benefit as much as possible. I am almost done with my remarks, but I have a short announcement I want you all to consider. We have other colleagues within our division who works on long-term care topics. It's just not restricted to NHSN. And they have a project that they're going to launch very soon. It's the assessment of infections and use of antibiotics in nursing homes and skilled nursing facilities. In the spring of this year, which is very soon, they hope to have about 200 facilities participate. And they will help collect data from resident charts and other records about HAIs, antibiotics administered and how they're used within long-term care facilities. The information will then be used to develop interventions and help inform surveillance efforts like that of NHSN and identify how to best support antibiotic stewardship. Here I have a table that lists all the states that we're expecting to participate and the counties in those states. All CMS certified nursing homes and skilled nursing facilities in these areas are eligible to participate. So we hope that if someone reaches out to you and you're contacted, that you will elect to become a part of this important study. So thank you all for your attention, and I will release you to the next speaker.